Now I'd like to invite Ryan Spencer to come up, a Geelong cardiologist, and we're going to get the slides up and have a quick update for AF. Thanks, Ryan.
All right. I'm not sure, am I the only person that feels a little bit itchy after that talk? Yeah, we're going to do an update on atrial fibrillation. I promise, unlike pre-bullous pemphigoid, there won't be any pre-atrial fibrillation in this talk. But asking an electrophysiologist to give you an update on atrial fibrillation in 10 minutes is a bit like asking Donald Trump to keep his tweets under 140 characters or less. So I'm going to struggle. But the short answer is, in terms of atrial fibrillation update from last year in 10 minutes, nothing has changed. So we could probably just all go and have morning tea now if you wanted, but I will try and struggle through. I guess the important thing, especially for those of us in contact with the community on the front line like you guys, is that there's something like 100,000 patients with atrial fibrillation wandering around out in the community that don't know it. And the problem for those people are that they're at significant increased risk of stroke, obviously compared to their fellow citizens. Screening, and even locally, so this is local data from 2014, we're still having more strokes per 100,000 head of population than other places in Victoria or the national average, so we've probably got some work to do. Screening for AF is really simple. Taking someone's pulse, or a lot of the electronic blood pressure monitors these days will tell you that there's an irregular rhythm, should prompt a 12-lead ECG, which will show you atrial fibrillation or not, and then you can evaluate the benefits and risks of treatment. So there's been some great studies, just sending cardiology registrars out to a shopping centre and getting them to feel 1,000 people's pulses, and subsequently coming up with somewhere between 20 and 50 diagnoses of atrial fibrillation that were not previously known about. So this is probably the most important thing we can do in terms of preventing atrial fibrillation-induced strokes going forward. There are other ways to detect atrial fibrillation these days. I'm not sure how many of you are aware of the Alivecor monitor here. We're using a lot of these in patients with paroxysmal palpitations that we cannot capture on other forms of monitoring. So they carry this around, it links with their phone, and when they get their symptoms, they can take a single lead ECG. And we've diagnosed quite a lot of atrial fibrillation, and also a fair degree of supraventricular tachycardia in people that have had long-standing palpitations that have basically given up on trying to capture their rhythms, and so it's been a good news story. Our pacemakers these days all detect atrial fibrillation if it occurs. Pretty much any amount of atrial fibrillation will cause an alert which will be sent to us, and then we have to work out what to do with that information, which is challenging. And the new loop recorders, this is the new loop recorder. It's about the size of a couple of matchsticks and is inserted basically the same way as you'd insert an Implanon. Is exquisitely good at detecting atrial fibrillation. And although we would typically implant them in people with syncope of unknown cause, they are now reimbursed for implanting in patients post-cryptogenic stroke, specifically to look for atrial fibrillation in those patients. This is my atrial fibrillation in one slide. There's lots of upstream factors which are important but difficult to fix. They cause atrial fibrillation. Once you make a diagnosis of atrial fibrillation, you have to deal with these two issues in every patient, and they're separate. You think about what is their risk of stroke or systemic embolism, and what am I going to do about rate and rhythm, essentially. So stroke and systemic embolism is easy. You calculate their CHA2DS2-VASc score, which we'll go through later, work out whether they deserve some kind of anticoagulation or nothing. Aspirin has no place in the management of stroke prevention and atrial fibrillation in the modern era. And you can ask me a question about that if you want later. Cardiomyopathy and symptoms, basically the first thing you do is get a transthoracic echo if they haven't had one, and then that will help dictate whether you're going to go down a rate or a rhythm way, also determining on symptoms, and the transthoracic will help you work out whether they have valvular atrial fibrillation, which may influence your decision about what anticoagulation to give them. So how do you differentiate valvular or non-valvular AF? It's become relatively simple these days because of the Noack trials have basically redefined what valvular AF is. It's basically a mechanical heart valve or moderate to severe mitral stenosis, which is almost always of rheumatic origin. And so as you can imagine, in Australia, very few people have valvular atrial fibrillation. Most atrial fibrillation in Australia is non-valvular, and that means they can take a Noack. If they have valvular atrial fibrillation, they really have to be on warfarin, but it's pretty rare. CHADS VAS score, so it's basically a scoring thing. You can have a calculator on your phone or on your desk or whatever. It's pretty easy. You just get a number of points for a number of things. Say in this case, we might have had a lady with hypertension. She's 75, 76, and she has female gender, so that would give you a score of around 4, gives you a stroke rate of around 4% per year. Anything above 2, basically, 2 or above, gets you onto anticoagulation. This was the old way we do things. It has been updated a little bit, and it's because subsequent data came out to show that the sex category, the female-male thing, probably doesn't convey an increased risk of stroke in the end. And so they changed the score to make it very difficult. You had to have different numbers. And then they thought, you know what, why don't we just get rid of the female gender character part of it altogether and just have a CHADS VAS score. So CCF, hypertension, age greater than 65, diabetes, previous stroke gets you 2 points, vascular disease, age greater than 75 gets you 2 points. Forget the gender. If they're 2 or above, anticoagulate. 1 you can consider, and this really comes down to how they get the 1 point. The strongest risk factor for stroke in all of this is age. So if they're 65, they definitely get anticoagulated. If they get their 1 point because of hypertension, and it's well-managed hypertension in a 35-year-old, you're not going to anticoagulate them. So age and diabetes are the strongest, and if they're CHADS VAS of 0, nothing. No aspirin, no anticoagulation. And this has been endorsed by recent guidelines. This is probably the only thing to change in the last 12 months, is that we now have Australian atrial fibrillation guidelines. So Cardiac Society of Australia and New Zealand put together these guidelines. People in Geelong were involved, like John Amarina, and they've backed up this score of the CHADS VA score, getting rid of sex category and saying greater 2 or above, definitely, 1 consider, 0 nothing. And again, antiplatelet agents not recommended. So Noack dosing, probably the biggest mistakes I think we see in clinical practice are not anticoagulating people or anticoagulating them at subtherapeutic doses. And the classic dose is seeing people on the 2.5 of apixaban, but we'll go through them all. Dabigatran, the lower dose is 110. Their trial didn't specify what type of patients should be on the lower dose because their trial randomised warfarin, a group of people on 150 BD and a group of people on 110. So we don't know who really should be on the 110 and the 150, but the recommendations are elderly patients, verapamil increases the strength, and if they have perhaps low renal function, although if they have low renal function, dabigatran is probably the worst agent because it's primarily renally excreted. The other 2 trials mandated which patients should be on the lower dose, so it's very easy. Rivaroxaban, the lower dose 15 once a day, low renal function. That's 15 to 49 is approved in the States. In Australia, it's 30 to 49, which probably shouldn't be using it under 30, but it's a grey area. Apixaban, the trial of 6,000 patients, there were 500 patients that qualified for the 2.5, but we see predominantly everybody on 2.5 of apixaban. It's because people aren't following the strict criteria of 2 out of 3 being age greater than 80, having poor renal function, and having low body weight. So AF increases your risk of stroke. Lots of people out there with undiagnosed AF, which we can find if we look. We should be doing as much opportunity screening as we can, and you want to concentrate that in the high-risk patients, which the biggest thing about getting AF is being older. If you have someone with new atrial fibrillation, pretty much everybody walking out of the consulting room probably should be on some Noack, and I'm willing to talk about the differences between the 2 if you'd like, but typically we would probably start apixaban 5BD and probably some rate control unless they were well rate controlled in the consultation. If you're seeing a patient in your clinic with atrial fibrillation, they've had atrial fibrillation for a long time, every time you see them, you should be asking, why are they not anticoagulated? Because obviously if someone gets diagnosed with atrial fibrillation at 50, they're going to end up on anticoagulation at some point. Their CHA2DS2-VASc score will get them over the line. It's just a matter of time. Okay. Any questions? Yep. Yeah, the Alivecor. Yep, I've got one. You can give it a go if you want in the break, and we'll see whether you're in atrial fibrillation. So, Alivecor, Alivecor. They're around $200. You can buy them off a website from Australia. They're made in the US usually. They're a bit of metal with a bit of plastic, and they communicate with your phone via sound. And there's an app on your phone which gives you a single lead ECG. Often the quality of the ECG is terrible, so you really have to educate your patients on removing muscle tremor, doing it on, there's techniques to get the trace looking good, but it's been revolutionary in those patients that keep having problems, but we can never quite get a rhythm strip. So we had a classic case. It was a pharmacist in town. He's had palpitations for 20 years, never been able to capture it. Very frustrating, often happens at work. Acute onset, acute offset. So fairly suspicious for something going on. We gave him an Alivecor. That night, he captured an episode of SVT, and we ablated him a week later. It's gone. So we hire them out of our rooms. So patients come in with their palpitations. We look at what tests have been done. If we can't capture on a Holter or maybe a 7-day event, you can get an event recorder from Barwon Health, which patients can take away for 7 days, which has a button. So that's an option, but obviously some people's palpitations are even more rare than that. We will hire them an Alivecor for a couple of months and see what they can capture, and then they'll come back and see us. So it's something to think about. I'm not sure. It opens a can of worms, though. So think very hard about whether you want to go down that path yourself or whether you're happy to refer those cans off. Because we obviously detect a lot of sinus rhythm. Yep.
What about, I have the patients coming with fitness trackers?
Fitbits and things. Yeah, so Apple Watches. Yeah, so we looked a group with myself and some other researchers at the Austin looked at Fitbit and Apple Watch and the accuracy of those devices compared to standard Holter monitoring, and it's fairly good, but it's not 100%. It's probably more like 70%. So I think that data is worthwhile, but it's not enough to act on. So as in, it's not enough to go from a Fitbit tracker that shows, an acute heart rate rise and fall. We're not going to take that patient to the lab for an EP study. Yeah, but it is that they are fairly good, and so I do ask my patients if they have them to show me the data. And you look at things like, was it a slow rise in their heart rate suggesting sinus rhythm, or was it an acute increase where the heart rate went from 60 to 180 and then straight back down to 60? That would suggest SVT, things like that. And then we would often loan them an Alivecor to try and capture a tracing. Yeah. But also worthwhile, we looked at using those like Fitbit or an Apple Watch to look at what about rate control in atrial fibrillation, and they are fairly good at, making sure you've got decent rate control in atrial fibrillation. So, yeah. Yep.
In those that don't tolerate Noacs or other anticoagulation, is there a role for atrial appendage ablation?
Yeah, so that's the whole. So you got the patient and you think they're too high risk, or they have actually been on a Noack and they've had bleeding problems. In the past, we would have said, "Oh, what about aspirin?" Turns out, in all the trials, the bleeding rates of aspirin and the Noacs tend to be similar. So the chances of getting severe bleeding on a Noack versus severe bleeding on aspirin is similar, and you don't get really any benefit from the aspirin. So what we would say is you should try a Noack. If you don't tolerate the Noack, then we should be doing everything we can to try and make sure you can. So looking at other things that might influence your bleeding risk, and the has-bled score is probably the best one to use, but it really says, can you stop somebody's aspirin? And the common thing we see is you start someone on a Noack and you come back and you're taking a medication history a month later and they happen to mention that they're on aspirin. You never knew they were even taking aspirin, and they don't really need aspirin, for primary prevention of anything anyway, but they certainly don't need it if they're on a Noack. And uncontrolled hypertension would be the other thing we'd really try and get on top of in terms of reducing bleeding risk. But then, if you still have bleeding problems on your apixaban or your rivaroxaban, then left atrial appendage closure is probably the next step. And so what we do is basically put a catheter up into the left atrium, put a plug in a left atrial appendage, which is the blind ending tube coming off the LA where the clots are probably formed, and that blocks that area off from the circulation and should prevent or reduce the risk of further stroke. And then they don't have to be on long-term anticoagulation, but it's probably not as good as anticoagulation. But we do them in Geelong, so it is an option. And the classic story will be someone in their 70s or 80s with a high CHADS-VAS score, so a significant risk of stroke, but then they have a big GI bleed, or they might have complex urological issues with ongoing hematuria, and the gastroenterologist or the surgeons just say, well, look, we can't fix this, they need to come off their Noack, we'll put the left atrial appendage closure device in and then stop the anticoagulation. Yep.
Thanks, Ryan. I think you probably half answered my question then. I'm just becoming increasingly confused about which patients should be taking aspirin and which shouldn't.
I know. It's, I think, thank God recently, at least we had some definitive trials come out suggesting something one way or the other, because before those last few trials, like the Aspirin trial came out, we really didn't have much information. It seems like, yet again, we can't find a primary prevention role for aspirin, no matter where we look. So, you look at healthy elderly people, they do not benefit from being on aspirin. You look at diabetics, they do not benefit from being on aspirin. No matter how we study aspirin in a primary prevention role, so before you have a heart attack, we can't find the group. No doubt they will be out there. No doubt there are people walking around that are such high risk that they're basically equivalent to someone that's had a heart attack, but in a trial sense, we can't find them. So I think certainly no role in the healthy elderly, no role in the hypertensive, high cholesterol, healthy elderly, potentially roles in that group of patients that you see that your clinical gestalt says this patient is very high risk for ischemic heart disease or stroke, and 100% remain indicated in secondary prevention. So previous stroke, vascular disease, or ischemic heart disease, definitely, no debates. It's really all, the debate is in that primary prevention population. Even when we study diabetics as a whole group, I would stop it in, say, a healthy elderly patient that was just taking it because their neighbour was. That I would say, the Aspirin trial, yeah, but a lot of people say, would you even just stop, the patient's been taking it for 20 years and hasn't had a problem. I would advise patients to stop it because there's trial evidence against that. The diabetic patient, I think, is hard because no doubt there will be some diabetics that are high risk. We just, when we study them, we can't prove that it helps. So I think that is how is this patient's diabetic control? What are their other risk factors? Have they got their cholesterol under control? If all their numbers are great, their HbA1c, their cholesterol's fine, their blood pressure's fine, I probably wouldn't have them on aspirin with the latest evidence, but I think that's where the grey area comes in. Yep. Yeah. I mean, in Noack, you really need to prove atrial fibrillation. So we have studied, cryptogenic stroke patients. They have a stroke, we don't know why. Should they be on a Noack? Probably not. You need atrial fibrillation to be on a Noack, but I would count that as equivalent of a stroke, basically, and so they should be on aspirin. Yeah, it's presumably an embolic phenomena, and so that would get them into secondary prevention. Should be on aspirin. Yep.
Can I ask if, say a patient's been in hospital, they've had an acute medical event, they've found to be an AF, they've been put on a Noack, they come back to general practice and they're always in sinus rhythm, got over their pneumonia.
Yeah.
When do we stop the Noack or do we just continue it?
It's a hard one, yeah. I think definitely if someone has interfered with the heart and they have atrial fibrillation, we're all comfortable that if you can prove prolonged sinus in those patients, you could stop their anticoagulation. So that would be, someone having a severe episode of pericarditis or someone having heart surgery. Certainly, we have strong evidence in the post-coronary artery bypass graft population that their atrial fibrillation around the time of the event does not increase their risk of future stroke because it's presumably due to the fact that someone's got a knife in their heart. But in the atrial fibrillation patients from pneumonia or from some other acute medical event, it's really difficult. The guidelines would say that they should stay on their anticoagulation lifelong. But I agree, it's hard when 3 years down the track or 5 years down the track, they still haven't had another episode. And I think that just becomes a discussion with the patient, taking into consideration their CHA2DS2-VASc score. If they're 65 but otherwise perfectly well, you could argue the CHA2DS2-VASc is 1. They're at a low risk anyway. They've been in sinus rhythm for many years. You know, you could make a discussion with the patient. What do you think about, let's come off the medication, see what happens. If their CHA2DS2-VASc is very high, you'd be worried that even the next time they go into AF, even if it is in the setting of a pneumonia, they're going to have a stroke. And that's the scary thing about the sinus rhythm population that have had AF in the past. You're always worried that the next presentation of AF is going to be the ischemic stroke. That's what they're going to rock up to the hospital with, an ischemic stroke, and they're going to be found in AF. And everyone's going to be, oh, why are they off their Noack?
Have they compared the rate of bleeding complications? I have recently had a patient who passed away.
Between the Noacks?
No,
Or?
on anticoagulation, with a hemorrhagic stroke.
Yeah. The rates of, I mean, we definitely see bleeding side effects from the Noacks. They're less than warfarin, so all the Noacks cause less bleeding than warfarin. Probably, there's some data that rivaroxaban might have a slightly higher bleeding risk, but it's once a day, so it's got real benefits in helping with compliance. The few people that I've said that have had strokes on their Noacks have all been non-compliant with their Noacks, so that is a concern. You know, you miss a couple of days or a day of apixaban, you're probably at risk of a stroke. You miss a day or two of warfarin, you're probably not at risk of a stroke, but the bleeding risks are significantly higher with warfarin, especially intracranial bleeding risks. So, I do tend to swap my stable patients from warfarin to a Noack these days because the data about intracranial bleeds is so strong. But I do have a few patients that are, very happy with warfarin. They've always been happy. I've presented them the data and they're happy to continue, and so I'm happy to leave them on it because, there's good things about warfarin as well. Yeah.
Thanks, Ryan. It's not quite on topic, but just the role of the coronary artery CT scans for diagnosing coronary artery disease.
It's a whole nother talk, isn't it? Look, I think in the sub-65-year-old population, it's not a bad test. Once you get above 65, coronary calcium starts to impede our ability to see the coronary arteries. So you might have a lot of calcium in your coronaries when you're 70. That means we can't say there's a narrowing or not. And the calcium itself, calcium scores, perhaps they're useful in younger people, but once you're 70, your calcium score is probably not going to be that useful. So you have to be young enough for us to see the coronaries, so sub-65. And then it does involve some radiation, but you get some interesting results. So you send them for a stress echo and you'll get this patient has significant ischemic heart disease or not. But what you won't get is they have, a 35 or you won't get a report that says they've got a 40% narrowing of their LAD, which is not significant. It's not going to cause them symptoms, but gee, it really does help you convince the patient to stay on their statin. So I use CT often as a test of, okay, this patient appears to be high risk and maybe they're having some very atypical symptoms. Maybe they're not. Maybe they're just coming to me for, I'm high risk, I've got a strong family history, I don't know what I should do, and they're not too keen on taking statins and aspirin or whatever, and I say, okay, well, let's do a CT. Either you're going to have no coronary disease at all, in which case I'm really not worried. A normal CT scan basically excludes the chance of an event in the next 5 years, or we're going to see some disease, probably not significant, we're probably not going to pick up a 90% LAD because he would be symptomatic, but it will show us that there's something there, and then that is going to push me over the line for really trying to convince you to be on a statin and probably aspirin as well. And then it's a good second line test. The other role I think it plays is you've had a non-diagnostic stress test. So you send them for a stress test or a stress echo, and we say not sure. So they've got symptoms. They're not high risk symptoms, which you might just refer in straight away. Maybe they're atypical, not exertional, occasional chest pain, left, right side, moves around a bit, not sure, but got some risk factors, concerned, you send them in for the stress echo and we say, not sure, pictures were terrible, couldn't tell. Then a CT scan at that point is a really good test. I try not to use it as a first line test because of the radiation exposure. I try and use basic stress testing, but we are getting better and better with our radiation exposure, so.
Thanks, Ryan. With the rhythm control patients with AF, which are the subsets of patients who actually need rhythm control?
Yeah.
And just a little bit of on how to sort of choose the agent, if you can. Thanks.
It's tough. Rhythm. It's the bane of our existence. Rhythm control, really. It's symptoms, I guess, is the primary focus. So if someone's highly symptomatic of paroxysmal atrial fibrillation, they go in and out, and they know when they're in, then obviously you're going to try and maintain sinus rhythm. So, or the patient who, they're in chronic AF and you get them rate controlled and you prove their rate control is good with a Holter monitor and they come back and say, I still don't feel right, then I would cardiovert those patients and see if it made a difference. And sometimes you cardiovert them and they say, no, I still feel tired. You think, great, handball. Or they say, I feel $1 million, and you think, oh, now we have to try and maintain sinus rhythm, which is challenging. If otherwise their heart is structurally normal, so you've proved they don't have ischemia, they need some kind of stress testing and an echo to prove it's a structurally normal heart, then really any agent's fine, flecainide or sotalol. But they all have problems. So, sotalol causes prolonged QT. You really need to monitor that with an ECG, within 24 hours of starting the agent, and then again maybe a week or two later. So, and flecainide causes, QRS prolongation that can lead to ventricular arrhythmias as well. So, amiodarone, great agent, doesn't cause any acute arrhythmia, but we know, the long-term problems of amiodarone are huge, obviously. So, there's no great way to go. So, to be honest, when I get into rhythm control, I usually always send them to the rhythm clinic at Geelong Hospital. We have a specific clinic that does rhythm control in atrial fibrillation at Geelong Hospital. And the other reason to do that is they're not going to end up on the drugs for long because you're going to try and ablate them. So the drugs usually are a bridge to getting them an AF ablation, which in the private sector takes 2 weeks, but in the public takes 2 years. So you get them into the clinic as soon as possible. But those agents, sotalol, flecainide and amiodarone, they're fraught with so much danger, I would probably just be referring on. Yeah. All right. Thanks very much.